welcome to the, I'm going to try and count how many, the annual year here, but I'm not going to count all those years. The Morton Hickman Lecture, sponsored by the College of Family, Home, and Social Sciences. Just for your information, before we start, restrooms are up one floor or down one floor. They're directly below us, as you probably have noticed. They're under construction here on this floor. I'm Ben Ogles. I'm the Dean of the College of Family, Home, and Social Sciences, and I'm pleased to welcome you here for this annual event. This is an event where we celebrate one of our top scholars in the college each year, and this year we're pleased to hear from Dr. Morton Hopkins, who's an outstanding scholar, and we'll get to hear about her research in just a minute. Before we have the invocation, I'd like to just say a few words about Morton Hickman. Morton Hickman served in the position that I currently serve in as Dean of the College of Family, Home, and Social Sciences. I'd like to actually just read through the whole introduction to him that's on your program, because it's really quite astounding. Maybe it's more astounding to me than you all, because I know how difficult this position is. And for him to accomplish as much as he did is pretty remarkable. He came to BYU in 1967 after a career as a foreign service officer in Hamburg, Hong Kong, and Berlin, and 5 years of teaching at the University of Southern California. In 1968, Morton Hickman was named the acting dean, in 1970 the dean of the College of Social Sciences. And then in 1980, he undertook the very difficult job of unifying a portion of the College of Family Living and the College of Social Sciences to create what is now the College of Family, Home, and Social Sciences. As the dean, he was instrumental in making possible the pursuit of many faculty interests. You see some of these listed here, and these are pretty remarkable achievements. The Women's Research Institute, which eventually assisted the Women's Studies program, the David M. Kennedy Center for International Studies, that has numerous programs for international studies, such as Asian Studies, Latin American Studies, International Relations, International Development. A lot of students in those programs. And the Family Studies Center from the School of Family Life, and other research efforts. And then on the teaching side of things, he also was passionate about teaching. He helped to organize the American Heritage Program, which is, of course, our general education course that all students take on campus. He was part of conceiving it, organizing it, presiding over it, and was even one of the teachers in that important program. It still operates today as a collection of our political science, economics, and history faculty. It's having served as a dean at another institution, I can tell you it's a remarkable thing to have an interdisciplinary course like that 3 departments collaborate on and effectively run for an entire university. It was something that many universities envy, truthfully. He was a remarkable man, and he did a remarkable work for this college and for BYU, and it's because of that, after his years of service, they established this lecture in honor of Morton B. Hickman, and it's the Morton B. Hickman Scholar Award, which features an annual lecture by one faculty member who's selected because of their achievements in scholarship. Tonight, again, Morton Hopkins. In addition, just a few years ago, the college started 4 new teaching awards, and we named these the Morton B. Hickman Teaching Awards. And so those individuals are named each year in our fall conference. I want to name them here. Curtis Child from Sociology, who received the Excellence in Teaching Award. Neil York, who received the Morton B. Hickman Achievement in Teaching Award. That's for a career-long achievement. Jason Carroll, who received the Hickman Innovations in Teaching Award. Jason Carroll helped to establish the new Eternal Family class that's shared between religion and our School of Family Life. And then Jamie Bartlett from Anthropology, who received the Excellence, the Hickman Excellence in Teaching for an adjunct faculty member. So these 4 teaching awards and this research award are all in honor of Morton B. Hickman. We have some of the Hickman family members here, some of his daughters and others, I think some cousins. If you guys would stand so we could just recognize you, the Hickman family. Thank you for always being here and supporting us, and we hope that it's a fitting tribute to Morton Hickman. We'll now begin with an invocation by Kaylee Carbine, a PhD student in neuropsychology, and then Michael Larson, a faculty member in the psychology department, will introduce Dr. Hopkins, and then we'll have the privilege of hearing from her. And then we'll have a few questions at the end, and I'll return after that. Katie.
Our dear Heavenly Father, we are grateful that we're able to gather and celebrate the achievements of Dr. Hopkins and to be able to hear from her and learn more about her research and her career. Please bless her as she presents what she has prepared this evening, and we are grateful for the important contributions that she has made to the psychology, neuroscience, and intensive care fields, and for the example that she has set. And we say these things in the name of Jesus Christ. Amen. Amen.
It's my privilege to introduce Dr. Hopkins. I'll start on a brief personal note, then we'll get into the introduction. Mona was my mentor in 1999 when I first was trying to decide what my career would be. And I spent many hours up on the 12th floor of this building tracing cingulate gyri as I decided to become a neuroscientist. So it was Mona's efforts that encouraged me to be there, so I feel honored to be able to introduce her tonight. Dr. Hopkins is a professor of psychology and neuroscience and a director of the Neuroscience Center here at BYU. She served as chair of our department in psychology from 2006 to 2012. Her research focuses on neuroimaging, cognitive and psychological outcomes of patients and family caregivers after critical illness. She has written or co-authored more than 220 peer-reviewed book chapters and articles. She's a recipient of a number of awards from BYU, including the Young Scholar Award in 2004, the Carl G. Mazur Research and Creative Arts Award in 2010, and the 2011 Jack Bailey Teaching and Learning Faculty Fellowship, and the 2013 Sponsored Research Recognition Award. Mona's research is really truly pioneering in this field, and she's one of the first people to have systematically looked at cognitive changes associated with critical illness in the ICU. So, very cool stuff. I'm looking forward to the lecture, and please join me in welcoming Dr. Mona Hopkins.
Thank you, Mike. Thank you for this great honor of being the Hickman Scholar and joining such a prestigious group of faculty. Critical illness. So many of you may not know exactly what I'm talking about when I talk about critical illness and how big the problem really is. But there's about 5.7 million patients admitted to intensive care units in the United States each year. A lot of those, 700,000, get mechanical ventilation, the breathing machine. 200,000 have acute lung failure or acute respiratory failure. Almost 500,000 or over 500,000 die in the ICU. In fact, 1 in 6 Americans will die in an intensive care unit, which is similar to the number of people who die of cancer each year. So this is really a problem that people haven't really talked about. And for each of us in this room, we will have an average of 1.7 ICU admissions in our lifetime. So if you average it across the United States, each of us will have a lot of ICU admissions. And one of the things that I just want to point out is in terms of deaths, this looks at deaths within a hospital, and the light gray is just a regular hospital room, but the dark gray represents the proportion of patients that die while they're in an intensive care unit. So many people die, but many people survive. And more recently, since 1990, when I published my first paper, the survival rate has risen to 80 to 95% of people that are admitted to the ICU. So that means there's 5 million survivors every year, and 2 million of those are over the age of 65. So this is a huge population. And they're discharged to the community, whether that's to a nursing home or a long-term care facility or home to their family. And they have new problems after they leave the ICU, or existing problems become worse. And these are remarkably common, they're devastating, and they result in problems like poor quality of life and the inability to live their normal functioning. So if you look at this graph, what I've circled in red shows the number of survivors in 1999. Up to now, you can just see this exponential increase as intensive care has gotten better. We're keeping more people alive, which means more people are going to have survive and have problems. But for patients and families, survival is not the endpoint. They want to return to normal and have high functioning and a high quality of life as possible. So when we think about what I'm going to tell you, think about how that's going to affect patients' quality of life. So this is a picture of an ICU in 1999 at LDS Hospital in Salt Lake City. Critical illness is severe and life-threatening. Things that will lead you to an ICU are things like stroke and kidney failure, respiratory arrest, cardiac arrest, or sepsis, which is a huge and growing problem that many of you have probably never heard of, but it's a systemic infection that's life-threatening. And when you're treated in the intensive care, we hook you up to all kinds of things. So you're hooked up to a ventilator that's breathing for you. You have IVs and lines everywhere that are giving you medications to keep your blood pressure up, keep your heart normal. We've got all kinds of monitors looking at what's going on. You can have a feeding tube because obviously if you've got a ventilator on, you're not eating. You have all kinds of electrodes monitoring everything, catheters that are going into your blood. And so we're measuring lots of things. But even importantly, you're experiencing lots of things like pain, delirium, which can be caused by illness or the treatment or the medications we give you. We put you in a bed and you're immobile. You don't sleep right because, of course, we're a hospital, so we keep all the lights on. And then there's all these alarms going off on machines, and people are coming in and out of your room at 2 o'clock in the morning for what appears like no good reason to you, but has some important reason to keeping you alive. And you have lost your autonomy, and it occurs at any age in life. So this is a letter one of my colleagues received from somebody that left their ICU, and she's writing to say, you know, I really hate to be a bother, but I have some problems that I'm having since I've been out of the ICU. She'd been out of the ICU for 2 years, and she says primarily, how long will my memory be affected? I'm having daily problems remembering people's names that I've worked with for years. I can't remember where I put things. I don't remember how to do simple multiplication. I can't balance my checkbook. This is really affecting my day-to-day life. I just want to know what to expect and if there's any way for me to improve. So this patient was 49 years old. This is not very old as I get older. This is becoming really young. She's had an honors degree in mathematics. She was employed as a corporate manager. She had no prior history of psychiatric or health problems or cognitive problems. She was hospitalized with pneumonia, and then the pneumonia got worse and she was transferred to a level 1 trauma center. She had a lack of oxygen and blood flow. She was put on a mechanical ventilator to breathe for her. Then she went into renal failure, her kidneys quit working, and then she became septic, had a systemic infection. She was on the ventilator for 31 days. She was in the ICU for 37 days, 43 days total in the hospital. And then she spent 21 days in a rehabilitation hospital. So these are some cognitive tests, and I've just, it's less important to know what they are, is that what they measure. So these measure executive function, your ability to make decisions, plan, organize, really make your life work. And these are memory. And the line I've drawn right here is the average score on these tests. So if you're average, that's where you'd fall. And what you can see for executive function, at 1 year, she's way below average. And think about what an executive has to do. A CEO has to make a lot of decisions. And that improved over time, but her memory was really bad at 1 year and really didn't improve much at 2 years. So this was affecting her ability to do her job. These are some pictures of her brain that were taken in the hospital. This is called diffusion tensor imaging, but these white areas reflect fluid or edema, extra fluid in the brain. And when these were taken, she was basically told, well, yeah, this doesn't look great, but it will probably just go away. And when we re-imaged her at 3.5 years, what you can see is substantial loss of brain tissue. Remember, this is somebody that's now 52, not very old, and she's had a lot of problems with brain loss. You can see this widening of the sulci, the grooves in the brain, the ventricles enlarged that are filled with fluid that protect your brain and cushion it. And so we can see changes over time. So this really led us to start thinking about critical illness as a brain injury. And so what does it mean when we have a brain injury? Well, this was a study we published in 2006 in only 15 patients, because at that time I was just hypothesizing there was a real problem. And what we can see is we match people with acute respiratory distress syndrome to healthy controls that had come in to have a CT scan for headaches. And here's both of these are 36-year-old women. These are the ventricles. So here's the front of the brain, the back of the brain. These are the normal size of the ventricles. Look at how much larger these are in the other patient. There's a lot of brain tissue loss, and it fills up with the cerebral spinal fluid. And these are 54-year-old men, and you see exactly the same thing. And we quantified this, and what we found is compared to controls, we had a lot larger ventricles than space, and then the ventricle to brain ratio is the ratio of how much brain you've lost, and that was significantly different. This is a study I did with Jim Jackson, Wes Ely, and others at Vanderbilt. And so they were wondering if they could replicate this study several years later. And so what they did is the same thing. They put them in the scanner. These patients, there were 8 patients with delirium. And you can see all these little white spots in the brain. Those aren't normal. Those are indications there's some pathology going in the brain. We're not exactly sure what's causing it. A few of us get them as we age, but most people don't get them this young or this often. And then you can also see the same thing where you have this enlargement of the ventricle, so you're losing brain tissue generally throughout the brain. And here's this patient again. So we can see a 42-year-old woman. This is a very large ventricle. This is even larger. It's a different slice throughout the brain, so front of the brain, back of the brain. But what they did at Vanderbilt is they measured delirium. So how many days were they delirious? They really didn't know what was going on in the ICU. And so on these graphs, you can see as delirium increased up to 12 days, the ventricle to brain ratio got larger. And then in these patients, this is the hippocampus, which is critical for your memory. The more days you were delirious, the smaller your hippocampus was. And this is your frontal lobes where you make decisions, executive functioning. Same thing. The more days you were delirious, the smaller your frontal lobes were. So now we have growing evidence that there's actual damage to the brain. So as we think about ICUs and what they do, they once focused exclusively on keeping you alive, survival. But we now know that there are multiple interrelated morbidities that last for years, and they may be permanent. And this constellation is called post-intensive care syndrome. So this is a Society of Critical Care Medicine task force that I served on for 4 years. And we pulled the literature together, and we recognized there was this problem that was affecting millions of survivors in the ICU. And so a bunch of us that we call stakeholders that were doing research, and clinicians and related organizations like AARP came to this meeting, and we talked about what all this meant, and we coined the term post-intensive care syndrome. A lot of that is about having a unified term to talk about and to publish about and bring awareness of this to people. And so since that time when we coined the term in 2010, there have been over 100 articles published that use the term post-intensive care syndrome. There are a lot of others that measure this that just don't use the term. So we've really seen this uptick in the number of studies that are looking at what happens to people after the ICU just by having a meeting and putting a name to the problem. So this is what post-intensive care syndrome is. So for the patient, they have new problems with mental health, so anxiety, depression, PTSD, or post-traumatic stress disorder, and acute stress disorder. They have cognitive problems, like problems with executive function, memory, and attention. They have physical problems, so they can't walk, they lose muscle mass, they have problems breathing because they're having weak muscles in their diaphragm and lungs. And then it has, at the time we talked about having problems with quality of life, but we now know that there are a whole bunch of these other things that are affecting their functioning or causing disabilities for them, like joblessness, financial difficulties, problems with social interaction, activities of daily living, which are things like being able to manage your medications or pay your bills or balance your checkbook or follow a recipe. And then we also know that it affects their family, and I'll talk a little bit more about that a little later in the talk. There have been increasing numbers of stories in the popular press about people that have survived writing about their experience. Since we came out with the term PICS, they now have a name to put with what they're experiencing. And before that, they really describe themselves as the forgotten patients. They're struggling to understand why they're having so much trouble after being returned to their homes and their families, because where they were told when they left the ICU, well, it's great, you survived, you're alive, you're going home, but nobody told them that they might have problems after this. And so a lot of patients have really talked about how important it is that they know what's happening to them and that they can put a name to it, and then they can start trying to get some help for this. So I'm going to first talk about some of the early research we did in cognitive impairments. I published the first study in 1999, but I'm going to jump clear to 2005 and look at the study where we followed patients during the hospital after they left the intensive care unit at 1 year and at 2 years. And if you can see, this is percentage of people that have cognitive problems. And at hospital discharge, it's about 78% of people had significant cognitive problems. And at 1 year, it dropped to about 43%, and it didn't really change after that. So at 2 years, they looked exactly the same. And this has been replicated by other studies over time. So I'm just going to give you a sense of what we mean when we're going to measure memory or we're going to measure attention. So this is a test that we look at for visual memory. And we give them this figure. It's called the Ray-Asteroth complex figure test. So we give people this figure and we say, okay, I want you to copy it. So we leave the figure there and then they have to copy it. This is a real person that did this that had problems. And so here's their copy. It's not too bad. There's a few things that aren't pretty perfect here. There's a few things that are missing, like there should be a little line here. But for the most part, this is a pretty good copy. Then we don't tell them, but we wait 30 minutes and then we say, hey, do you remember that figure I had you draw a little while ago? Could you draw it for me again? And this is what the person drew. So you can see that over time, they're not remembering what the information that they had while they copied the figure while it was sitting there. So you can see this huge decline in memory in a very short period of time. 30 minutes is not very long for how long we need to remember many things in our lives. So this is more recent work that I've done with Del Needham at Johns Hopkins University, and we did a multi-center study from 5 sites around the United States at Johns Hopkins, Intermountain Medical Center in Salt Lake City, Vanderbilt in Nashville, Washington, Harborview Medical Center in Seattle, and at Duke in North Carolina. And we followed patients at 6 months and 12 months. And the names of the studies are really not relevant for what I'm going to say here. But these were patients that had acute respiratory failure. So they were having trouble breathing, they couldn't get enough oxygen in, they came into the ICU, they were put on mechanical ventilation, and they were there for various periods of time. But when we look at just cognitive impairment at 6 months, these are 2 different studies that we ran. It was 36% at 6 months, and it got a little better at 12 months. It was 25%. But in a completely separate study that only a few patients were co-enrolled between these 2 studies, look at the similarities in the percentages. It's 37% at 6 months and 29% at 12 months. So this really shows that across studies, these things are showing up. And again, this is a multi-center study, so it's done across in 5 sites across the country. And so we have some better ideas than if I just do it here in Utah. In fact, I've actually heard the complaint that if I do it in Utah, of course they have better cognitive function because we don't drink, we don't smoke, or many of us don't drink and smoke. and we're highly educated. The average education in our state is almost 13 years. So it's nice to see that this holds up across the country as well. It's not nice for the patients, but it's good for research to know that what you're finding is replicable. So in this study, I've already told you about the overall cognitive impairment. So this is the red bars are 6 months, the blue bars are 12 months. You can see the percentage of people that have problems with executive function. Language doesn't seem to be impaired in this group. These are memory, all of these are memory, and depending on what type of memory that we're measuring, they all have problems with memory. And you can see in some cases, it does get a little better at 12 months, but I want to point out that everybody's not getting better. There are some people that are having these problems that are persistent over time. They're just staying and they're not going away. This is also a study I was part of at Vanderbilt. This is a multi-center study in over 800 people. And we were looking at cognitive impairments after baseline. So they had a baseline measure, and they had about 6% that had some mild cognitive impairments at baseline. So most patients didn't have any prior cognitive problems. 74% of these people were delirious in the ICU. Some studies say 100% of people get delirious in the ICU because we're disorienting you and we're giving you sedatives and narcotics and all kinds of drugs for pain, and atypical antipsychotics are used, and so there's a lot of problems. But when we measure outcomes in this group, this was at 3 months and 12 months, it's 40% at 3 months and 34% at 12 months. So again, a little bit of improvement. But I want to make a point with this slide. So this group is less than 49 years old. This group is 50 to 64. And this group is over 65. And it doesn't matter what age you are, they all have cognitive impairments. So there was this theory that it's only the elderly that are in the ICUs having this problem. Well, we know it's not. In fact, the average age in most studies is 55. And then you can see how bad the cognitive impairments are. Here's the normal range, this green line. Here's what we would call mild cognitive impairment, which may be a precursor to Alzheimer's. For some individuals, not everybody, generally just has some mild memory problems. And then we have traumatic brain injury, moderate to severe traumatic brain injury, and then moderate to severe Alzheimer's disease. And you can see that these patients all fit within all of those definitions. There are some that are more mild and some that are more severe. But these are significant cognitive impairments when you're talking about Alzheimer's disease, mild cognitive impairment, or moderate to severe traumatic brain injury. So they didn't have that, but that's what they look like. Okay? So what about the psychological disorders that patients have after critical illness? This is a colleague of mine that's at the Vanderbilt VA sent this to me, and I really appreciate it because it really illustrates some important things. So this is what the sister is saying about her sister that was in the ICU. You remember my sister is 64 years old. She's a CEO with many employees. She developed delirium. We couldn't seem to get her mental clouding cleared for quite some time. She's tried to go back to work and driving and functioning, although she can't seem to fully bounce back. I saw her about a month ago. She seems to have lost her spark. She was such a personality pre-illness, so gregarious, and really the life of the party. She is very flat now and has memory problems. She doesn't remember anything about her illness or her hospitalization, some long-term, but mostly short-term memory problems. She looks much older, is walking very slowly, holding on to rails. She looks like a very elderly woman. The illness really changed her. So the family member is describing a lot of things that I would call psychological as well as physical and cognitive problems in her sister. So in these same two studies that we did in those 5 hospitals, we measured depression. And we looked again at 6 and 12 months. And in the first study, the percentage of patients that had depression 6 months and 12 months after leaving the ICU is 37%. Doesn't change. And in the second study, it's exactly the same identical rate. And no, that's not an error. That's really what it is. For the scientists in here, it's not an error. So you can see that this is pretty significant, which is a little different than cognitive problems because the depression is not getting better. And if we look at anxiety, it's even higher. It's 45%, almost half of patients. It slightly declines, but not really. And it's 46% in the second study. And if we look at post-traumatic stress disorder, it's 26% and 23% at 12 months. And in the second study, it's 25 and 26%. So these problems are quite common. If you think a quarter to almost a half of people leaving the ICU have new post-traumatic stress disorder, which is higher than the rate that we see in returning veterans from wars in the Middle East. This is a really significant problem. It's really something that they're concerned about and is very difficult for them. So in this case, we saw no change over time or no improvement over time. So these patients are really struggling with lots of problems. If we look, this is a systematic review of 38 studies, and they were just looking at for how many people had depression across all these studies. And so they broke it down several ways, but one of the most common instruments is called the Hospital Anxiety Depression Scale, and they just used that to see how many studies. So there were numbers of studies at 12 months, or 2 to 3 months. You can see that it changes over time because each study doesn't follow people at the same period of time. And the number of patients also changes over time, but it's over 1,000 at 2 time points and almost 800 at the second time point. And what you can see for depression, the prevalence rate is 29%. At 6 months, it was 34%. And again, that's partially because these aren't the same studies going across these times. And then at 12 months, it's 29% again. So just looking at all the studies that have been done, we see the same kind of thing happening across multiple studies for patients that have problems. And this is an article that a physician who was in the intensive care wrote about her post-traumatic stress disorder symptoms. So she's a physician. I would make detours while traveling to avoid the sight of a hospital. I could not watch hospital documentaries or dramas. I hid all my medical textbooks and journals. I enjoyed sport, but began to avoid exercise as I was terrified of the sensation of breathlessness. Even certain inanimate objects filled me with fear. I still cannot bear a shower curtain to be drawn. It reminds me of them closing the hospital curtains and hidden death. So these are the kinds of things they have, the things they re-experience when they have post-traumatic stress disorder. So it's very similar to veterans re-experiencing combat or bad things that happened to them while they were deployed, coming home and having these things. So it's very graphic and it's real. We also know people remember things that didn't happen that are what we call delusional memories, but they're very disturbing. So they will tell, I've had patients tell me that the doctors and nurses were selling drugs in the next room. I had somebody tell me that a former Vietnam vet that he had been tied up, which we do restrain them so they don't pull their tubes out, and that they put a gun to his ear and they cocked it and just pretended like they were cocking the gun and shooting it, but it was empty. But we use ear thermometers and they click. Okay? So there are delusional memories and then there are these real life memories. So you have a physician, her career, that can't really manage anything to do with what she has loved and what she went to school for all those years to do. So if we look at post-traumatic stress disorder, this is again 40 studies that were analyzed by Parker, Del Needham's group, and Johns Hopkins. And there are over 4,000 patients. And the important thing is post-traumatic stress disorder is common. At 1 to 6 months, it was 21% across about 400 patients, and it was 17% at 6 to 12 months. So there is some improvement with time. And across most studies, it ranged from 10% to 32%. So again, this is rates as high or higher than what we see in veterans returning from war. We also know, this is a study that I did with Johns Hopkins, that We looked at the co-occurrence of these things. So we know everybody has all these problems. So how many people only have one problem, or how many people have all three psychological problems? And so you can see the white areas are only one problem. This group only has anxiety. This group only has depression. This group only has post-traumatic stress disorder. This is two, so this would be anxiety and depression, or anxiety and post-traumatic stress disorder, or post-traumatic stress disorder and depression. But this dark group in the middle, 33%, have all three disorders. So it's not just that they're experiencing one problem, they have three problems. And many of them aren't getting treatment or help for any of these problems. So we have a huge compounding problem. So we've got cognitive things, we've got physical problems I haven't talked about because I don't have time to talk about it. And then we have all these psychological problems that we're seeing in patients that survive the intensive care. So this is a study that I was part of the brain ICU study at Vanderbilt. And in 448 patients, we looked at depression. 37%, these numbers look like my other studies, had depression at 3 months, and 33% at 12 months. 7% had PTSD at 3 and 12 months. This is a lower rate than most of the studies are finding, and so it's very interesting because we're trying to figure out why. And one of the reasons we think it is because Vanderbilt has come up with a very aggressive protocol to keep people from getting delirious while they're in the intensive care unit. So we keep them awake, we don't give them as many drugs, they wake them up, they get them up and walking. It's what's called the ABCDEF bundle. So you awaken them, you breathe them, you stop their sedation, you get them up and ambulate them, and you have their family around to help orient them. And so we think that those things might be contributing to this, but we don't really know. But we do know that they also have problems with activities of daily living, things like feeding, dressing, bathing. And it was 32% at 3 months and still 27%. Those are pretty basic functions. A lot of this comes from their physical debilitation. And they also have functional problems from their mental health that I'll talk a little bit later about. So we were interested in trying to figure out if we can figure out if everybody has the same pattern of problems, or are there subgroups? You know, is there different ways that people experience these kinds of problems after critical illness? And so Sam Brown in our group took the data from the two studies that I've been showing you from Johns Hopkins that we were involved in. And then this is sort of what this means. So this is cognitive screening over here, cognitive tests, or cognitive function. This is fatigue. These are the mental health, PTSD, depression and anxiety. This measures depression and anxiety. These are physical function. This is the functional performance inventory, and this is just a measure of physical function. And then this is quality of life. And what you can see when we had a huge group that we could analyze and try to look for patterns is we really see 5 or 6 unique patterns here. The first is that the mental health and the physical problems seem to go together. But there's 4 unique patterns in this whole group here. So you have mild physical and mental health, you have moderate physical and mental health, you have severely impaired physical health but moderate mental health, and severely impaired mental health but moderate physical health. But what's interesting is cognitive function is completely independent. So if we're trying to come up with some way to treat people or to help people, we can't use a sort of one-size-fits-all approach because these things are seeming to be different across different people. So that how their cognitive function doesn't track with their physical and mental health issues, even though they're having those as well. So this was just recently published, and so this is really getting us to think about, can we identify subgroups of patients on the front end and then see if we can do some interventions to help them on the back end. And then fatigue doesn't go with anything either, and we're not sure what to do with that except for everybody that comes out of the ICU is fatigued. Okay? So what does this mean for impairments in daily functionings or disabilities? So this is again, Sam Brown in our group did this study in our multi-center study, and he really looked at quality of life and what we call health utilities, how How bad is their quality of life? And it's generally lower in ICU survivors. But the interesting thing, even though this happens after they've been in the ICU, things that are medically related in the ICU aren't related to this. So it doesn't matter how long you were in the ICU, how sick you were, if you were on mechanical ventilation. We've measured a lot of different things, and for most studies it doesn't come out. What does come out are things like age, female sex. These are people that have worse outcomes. If you have a Hispanic or Latino ethnicity, we have no idea why any of these come out yet. Require professional health at home, or lifestyle factors like smoking or being overweight, a large body mass index. So there's something that's happening on the pre-ICU. Maybe these people are healthy, they don't have heart disease or diabetes, but some factors are triggering their outcomes to be worse. Now this needs to be replicated. This is only one study, but it's intriguing to think about. Can we start saying that if you do the healthy heart diet and you exercise and you prevent all your cardiovascular risk factors, are you going to have better outcomes when you leave the ICU? And that's something that you can start putting into preventative medicine if that were the case. But again, this needs to be replicated. We also did a review of instrumental activities of daily living. So these are things, again, like cooking, being able to manage your medications, pay your bills, do those kinds of things. So we found 16 studies that had studied this in an ICU population, and the number of IADL dependencies ranged from 70 to 85% of patients. 69% had new or worsening problems, so that means if they had a problem before, they were struggling maybe to manage their finances, it got worse after they were in the ICU. We didn't find it, there were lots of risk factors that were identified across the studies, but none of them were consistent, so every study had a different risk factor, which gives us lots of things to think about and study, but it doesn't help us any clues about what's going on. And then if we look at studies that follow people over time, so each different color is a different study, and you can see that they follow at different times. But universally, the instrumental activities of daily living improved over time. So that's some hope that there are things that we can do to intervene to make this better and get more people improving and back being functional, living independently. This comes out of the studies, again, that I did with Johns Hopkins. We looked at, as part of our outcomes, we wanted to see about joblessness. So employment is a really important functional outcome. Remember, most of the average age of people in these studies is 52. I don't know how many of you could live without an income at 52. Probably not many of us. So it also is a marker of economic well-being, your sense of self, your quality of life. And so we looked at people in our study. There were some people that were not employed before they got sick, but of those people that were employed, of these almost 400 people that were employed before they got sick, less than half are back to work at 12 months. And the average time to go back to work was 13 weeks, and 40% had a different occupation. Now, I love what I do as a professor. I don't want a different occupation. I want to be doing what I love, and so this would be devastating. And then you can see that 71% lost earnings of over $27,000 in 12 months. So it's their earnings plus their caregiver, their spouse, that's taking care of them, that's not working as much or had to go part-time or took a family leave to take care of their loved one. And 58% are receiving new disability due to functional impairments, like impairments in activities of daily living and instrumental activities of daily living. So what about the family members? So if you're in the ICU, your family members are usually there, and they're sitting in the room, hopefully. Your ICU has open visiting hours, and they're able to be with you, but they're watching all these things that are happening to you. And it's very distressing when your loved one is this sick. So it's crucial to the patients that family members are there, but it's also crucial to recognize that family members have a lot of stress while they're there. They're watching this, and they're required to make decisions. The doctors are coming in saying, we need to put this tube in, do you agree? We need to get some x-rays, we need to do all of these things. We're not sure if they're going to make it or not, so you may have to make a decision about keeping them alive or not. So family members are making a lot of tough decisions. They may have been caregiving for these people before the ICU. Many of them have not, but they might be after. So they're suffering in their own right. And so the studies that are out there show that psychological distress, including complicated grief if the loved one dies, or even if they don't and have new problems, happens to caregivers. We also know that the majority of caregivers are female. They're a spouse or a partner. They're middle-aged. They have a high school education level of an education level of high school or less, and most of them are employed at the time their loved one was going into the ICU. So this is just to remind you, for the family, we're going to talk mostly about mental health and quality of life that happens to them after the ICU. So this is a big study that came out of Toronto, Margaret Herridge and Jill Cameron, and they show that caregivers have new depression, they have loss of employment, and they have overall weariness. And in the United States, $642 billion are provided by family caregivers. So this isn't something, a caregiver that's being paid, it's the family that's doing the work. Think about the financial costs of that to families. Of the caregivers in the same study, 43% have depression a year after their loved one was admitted to the ICU. And they have this loss of control. They've lost control of their life. Everything's changed for them. And so they're having significant problems with depression and coping with all these changes. If we look at anxiety, depression, and PTSD, and you look across time, you can see the rates are high. They're very similar to what they are in patients. Look at the rates of PTSD from watching their loved ones go through this very difficult experience in the ICU. Again, much higher than depression. But we also know that up to 32% of them take new medications for depression, anxiety, hypnotics to help them sleep, psychotropics to help them function in the world. And up to 12 months, 50% have to quit an activity, whether that's work or some other activity that was very important to them, to care for their loved one. They also have what we call learned helplessness, which is a sense of powerlessness due to a traumatic event, which in this case would be the ICU admission, and persistent failure to succeed. And it's associated with underlying depression, and this study by Sullivan found about half of ICU families have learned helplessness. So we're causing all of these problems for patients and their families, and we need to start thinking about what we can do about it. So are there things we can do about this? I'm just going to quickly show you a couple of examples. This is a study Jim Jackson did at Vanderbilt, and he did a combined telemedicine, physical rehabilitation, and cognitive rehabilitation. And here's a study enrollment. The controls are the dots, and the intervention group are the triangles, and you can see after the intervention, their cognitive functioning was better. This was a simple telemedicine intervention where he got on and Skyped with patients. They had an activity book, and they said, you do these exercises, and you do this cognitive stuff, and then they measured their function 3 months later. This is a psychological intervention that Chris Cox did, where they just talked to them by phone, and they gave them some coping skills by telephone. And we can see that it reduced depression, anxiety, and PTSD in both patients and their family caregivers. So these are simple interventions done by telephone. So this was 12 weeks for 30 minutes. And then there's a lot of studies going on, particularly in Europe. They're a little slow to hit the United States because we have a lot of medical legal issues that we're trying to deal with in this. But they give a diary of the patient while they're in the ICU to the family caregiver. And in Europe, the nurses write in them. In the US, mostly it's families writing in them. And it's really just saying what happened to you today so that they have a remembrance of what really happened to them that's factual. Because remember, they have delusional memories as well as factual memories. And so when we come back and ask them, 61% say it was beneficial for caregivers, 49% it was a useful tool just for communicating what was happening with their loved one, so the patient could see what happened to them and the loved one could go back and refer to this, because when you're dealing with all these things that are changing so quickly, you don't remember it all. And 33% say this should be a routine part of care, that just being able to write diaries. So this is really starting to hit the US, and there have been a number of studies and many of them have shown benefit. We also know that we need to get patients and families more involved. So ICUs for a long time have been very restrictive. You could come in for an hour in the morning and an hour in the afternoon. So we're trying to do this. I was part of a task force for Society of Critical Care Medicine looking at guidelines for family-centered care across the ICUs, across the lifespan. And we made a lot of recommendations like opening, visiting, allowing families to be present during procedures, and other things to engage the family. And there's a program that's running at Intermountain Medical Center called Partners in Healing, where family members now can do simple care tasks for their loved ones, and that engages them in the care and communication. So this is some recommendations that have been come up with. And currently I'm working on the Thrive Task Force, again for Society of Critical Care Medicine, and we're trying to come up with ways to help people. And so I'm going to, just as I close, show you a little video of this, about 2 minutes long, that shows some of the things that we're working on in Thrive.
Many people now survive critical illness. Healthcare professionals used to assume that patients who survived critical illnesses returned to how they were before. However, stories of patients with profound struggles after being hospitalized emerged, such as James, Maria's, and Ping's stories. James was a businessman. He had sepsis from a severe bout of pneumonia and needed life support for 10 days. For months after his illness, he was forgetful, had difficulty concentrating, and frequently lost his train of thought. James was asked to copy this drawing, and he drew this. Maria was a professor. She had severe influenza. Her kidneys and lungs failed, meaning that she needed dialysis and a breathing machine for 2 weeks. After her hospitalization, Maria had profound weakness. She had to learn to walk again at a rehabilitation center. Ping was in 4th grade when he was hit by a car. After being in the intensive care unit, or ICU, he went to a rehabilitation hospital. Ping talked little at rehab, but learned how to use his arms and legs again. He had a hard time reconnecting with his friends. During the past 20 years, research has confirmed that these types of stories happen more often than not. In 2010, the Society of Critical Care Medicine, or SCCM, gathered together experts involved in the care of ICU survivors. The group named the combination of problems common to survivors of critical illness post-intensive care syndrome, or HICS. HICS includes new challenges to the brain, body, and emotions, and is seen in more than half of critical illness survivors. Children surviving critical illness often have similar problems, such as delayed developmental milestones, learning problems, and sadness. Families and friends are also affected. For example, James' persistent problems led to his wife giving up her job to be his caregiver. Researchers are working to prevent and treat HICS. SCCM believes that ICU survivors can share their stories to help each other, which is why its Thrive initiative is building a network of face-to-face groups for critical illness survivors. In 2015, 6 Thrive sites were launched. In 2016 and 2017, even more will join. If critical illness has touched you or a loved one, please join us. Let's create a better recovery together. More resources about HICS and the Thrive initiative can be found here.
Sorry. Thank you.
We have time for a few questions. Let's take a few questions.
Yeah.
We spent about a month in care with my wife who has struggling. A lot of the things that she showed, we wrote a literature about stroke and brain injury and such. A lot of those statistics feel very similar to what we experienced with
great question. We do control, so this was really only people that had a medical or surgical ICU. We excluded cardiac surgery patients, neurologic patients, which would include stroke and Alzheimer's. So in almost all of these studies, all of those are excluded. We're really trying to look at this group that's been understudied and underrepresented.
Yeah, so in your studies you showed results at 3 months, 6 months, and 12 months. Do you have data on what trends are like in 2, 3, or 5 years?
We do. I didn't have time to show it, but there's several studies that have gone out to past 5 years to 5 to 6 years, and it's not changing. So that's why we think it might be permanent, because when you get out that far, that's pretty much hanging on for a really long time. Yes?
How did you get started in this research?
So I had a son that had an anoxic brain injury when he was 4, and I was really frustrated because I couldn't find the help that we needed to do this, and so I really got interested in the effect of lack of oxygen on the brain. And so the first group that we looked at were those patients that had acute lung injury or acute respiratory distress syndrome. They're very hypoxemic. They have low oxygen levels for long periods of time, even though we're aggressively ventilating them. And so that's the connection between lack of oxygen and the brain, and it's showing up across a number of studies.
So are the changes you observe in the brain, do you think those are due to the event that caused a critical illness or the time in the ICU?
So I think that's a really good question, because most critical illness that we're looking at is unexpected, it's sudden, we don't have any planning for it, so we're not getting everybody scanned before they got sick. And so it may be that some of these problems were there before, but we do know from the patients that we've seen that they're probably worse if they were there before, and when we can match with controls for the same age, we know it's pretty bad. But it's going to be really hard to completely answer that question because this is such an unexpected illness.
You could see like respiratory distress causing a brain issue, right?
Yeah, so things like sleep apnea, we know that if it's not treated over long periods of time, you can start seeing some decrease in the volume of the hippocampus, for example. But most of the kinds we see, things that we're seeing are really dramatic. They look more like severe traumatic brain injury. So even if people were having some age-related or disease-related changes, this is probably accentuating them. But again, it's kind of hard to, we'd have to scan everybody, and our current healthcare system wouldn't afford that, so, or any healthcare system for that matter. It's really expensive. But great question. Yeah, Dee.
Nice presentation. A lot of these features are seen in chemo brain too. But is there some commonality with that?
The biggest commonality that we're seeing with chemo brain, because there are direct effects of chemotherapy on different brain regions, is that we're trying to use what cancer survivors have known for years, is that we need support groups, we need other kinds of things. So we're taking what cancer has done and developing support groups for patients and families, and that's part of this Thrive initiative. So there are now 27 peer support groups, there's an online support group, and we are thinking that that's going to help their social, emotional issues as well, the psychological problems. But in terms of any relationship between mechanism, no.
Is this only for accident-related injuries, or is it also for like brain surgery or something of that nature?
So we excluded all the people that would have had brain surgery that ended up like in a neurologic ICU, and just looked at those people that ended up in a medical or surgical. So let's say you were in a car accident, you hit your chest on the steering wheel, that can cause respiratory problems to develop. So we're going to see you. We're going to see people with pneumonia, people with sepsis. People that are having surgeries are either that they were in like a car accident and they had a leg fracture, or there are some surgeries we have to do when they're really sick just to keep them going. So it's not people that have had this bad brain injury that we know on the front end.
Stop there. We have this nifty clock for a moment. the Outstanding Scholar for 2017-2018. Let's give her one more round of applause.